I'm going to talk about predicting the risk of readmission. As you can tell by the title, there's lots of gaps in our understanding of predicting who's going to get readmitted and who won't. And most of what I'm going to talk about is work of a systematic review we recently completed. Nora Englander was a co-investigator on that project, as well as Dave Kagan at the VA and some collaborators from Vanderbilt. So why is there interest in readmission risk prediction? Well, one reason is because, as you've already heard lots about, readmissions are increasingly being used as a quality metric. In order to compare hospitals to one another, you have to adjust for the patient mix. And hospital comparisons that CMS is doing for public reporting and financial penalty purposes are based on risk standardized readmission rates. And the risk standardization is based on these readmission risk prediction models. And we'll talk a little bit about some of the CMS models here. But mainly what I'm going to focus on today is the second use, the clinical utility of readmission risk prediction. So you've already heard that there's several interventions that have shown some promise in their ability to reduce readmissions. And ideally, you'd want to identify high-risk patients for intervention because there are some resources involved in implementing these interventions. So you wouldn't necessarily want to use an intensive intervention on a low-risk patient who wouldn't get readmitted anyways. Okay, in terms of clinical application, this is a graphic. This is from Dave Labby's graphic of what some elements of an ideal transition might look like. And you can see the highlighted box there. Risk assessment for readmission occurs, sometime after hospital admission and before discharge. And it might be useful for things like identifying patients who might benefit from a home visit and other things. So what would ideal models look like? Well, it depends on the intended use. So for hospital comparison purposes, you'd need reliable data that's easily obtained. These are applied to large numbers of patients, and the data is usually administrative claims data. It has to be deployable in large populations. It has to use variables that are clinically related to and validated in the target population. So if you're studying congestive heart failure patients, the model should be based on variables that are clinically relevant to heart failure patients and not pneumonia patients, although there'd be a lot of overlap, obviously. And lastly, the model should have good predictive value. It should be able to sort out patients that are high risk and low risk. Now, for clinical application purposes, we have more flexibility. In terms of the data we use, we don't have to stick to only administrative claims data. But the data does have to be probably available before discharge because a lot of the interventions begin before discharge. They should discriminate very high risk from very low risk patients. They shouldn't be overly complicated. If these are being implemented in clinical settings, a model incorporating 40 variables isn't going to stand the test of time. It'll be too complex to incorporate in a clinical setting. And the clinical model should be adapted to the settings and populations in which use is intended. So we still have to think carefully about the local populations that we're serving and how the model does or doesn't apply to those populations. So we have limited time, so I won't go into all of the methodology of our systematic review, but this is just the flow diagram from it. We looked at readmission risk models in medical patients, so we did not look at surgical populations, psychiatric, obstetric, or pediatric populations. We found about 8,000 abstracts, and of those we looked at 286 full-text articles and ended up including 30 studies of 26 unique models. And what did we find? Well, about half of these models were created for hospital comparison purposes and half for clinical purposes. But most models in both categories perform poorly in predicting readmission risk. So I purposely didn't put up a lot of data here, but I can just quickly describe in plain English what performing poorly, one example of performing poorly. So if you take a pair of patients, one who is going to get readmitted and one who isn't, we can look at the proportion of times a model is able to correctly sort out that pair of patients. Most models we looked at got it wrong 35 to 40% of the time. The 3 CMS models, heart failure, MI, and pneumonia, got it wrong about 40% of the time. There was only one model out of the 26 we looked at that explicitly defined and examined potentially preventable readmissions, and this was a Swiss model. We looked at the PPR model, but it was not a validated model and wasn't really designed as a risk prediction model. Most models used, the types of variables models used, not surprisingly, were medical comorbidity-related data, prior utilization, meaning prior hospitalizations, and age and sex. Very few models, however, examined broader sets of variables such as social determinants variables and functional status. We get some data from 6 studies that were able to compare different models within the same population, and that's probably the best way we can get a sense of the incremental value of different variables in predicting readmission risk. And 2 of these studies found that social determinants and/or functional status variables improved, although modestly, the predictive ability of models. So why is it so hard to predict readmission risk? You know, it's interesting, it's actually much easier to predict who lives and dies versus who gets readmitted. And this has been shown in several studies. And it's probably because there's lots of factors that contribute to rehospitalization risk. Obviously, medical comorbidities do, and this is where a lot of models stop. But there's other patient-level factors that may contribute, such as social support, low health literacy, marginal housing status. The Dartmouth Atlas stuff suggests that bed supply itself may contribute to readmission risk. In other words, if you have open beds, people tend to use them. Inpatient care quality could contribute to readmission risk, although the literature there is mixed. There's some studies that do find a relationship and others that don't. And then post-discharge care, or the lack thereof, may contribute to readmission risk. And we heard a little bit about that. There was an interesting JAMA publication just within the last year or two, which also looked at the Medicare fee-for-service data and found a large proportion of CHF patients didn't get early post-discharge follow-up. And it was associated with a higher risk of readmission, but the association, surprisingly, was relatively small. So it's an association, but it doesn't explain the whole risk. Okay, what are some implications of the review here? So this is the only one where I'll talk about the quality metric piece, and then I'll talk about more of the clinical implications. Broad-based comparisons of risk standardized rates, especially when they're tied to reimbursement, may be problematic and could be associated with unintended consequences. If we can't accurately predict who's going to get readmitted, can you really use it to broadly risk standardized rates and then use that for hospital comparison purposes? I think you probably can to a certain extent if it's just for public reporting and kind of getting people engaged in the discussion, but when you start tying it to reimbursement, there may be some issues. Interestingly, there was a recent study by Karen Joint, which found that the hospitals with the highest readmission rates were also those with the fewest resources and serving the poorest communities. And so if they're financially penalized, there's a risk of exacerbating disparities in care. The second implication, so for clinical purposes, and I'll be now the 4th person that has said the perfect does not have to be the enemy of the good. We didn't plan this together, but past studies have shown that even modest incremental knowledge of risk can improve the cost effectiveness of interventions. So even if you can just sort out some of the very low risk patients, it can contribute to cost effectiveness of your intervention, even if you end up treating some of the low risk patients. I think this one's important. It's important to match the model to the intended use. So models designed for measuring quality are probably not well suited for clinical use and vice versa. So I had recently seen that the CMS heart failure model has become, an electronic application that's being promoted for clinical use, and it's not really appropriate for clinical use. It's designed for hospital comparison purposes, not for clinical use. We can do better for clinical purposes. And it's important to think carefully about the local population to which models are being applied. If we're treating a large urban population that's socioeconomically disadvantaged with many homeless patients, it's probably important to include some of those variables, such as housing, in the model that you're going to use. And that may be less applicable to other populations. Given the lack of an existing risk prediction standard, it's important to incorporate clinically informative variables in your risk assessment that would not otherwise be captured. In other words, we have an opportunity here, given all the discussion around readmissions, even if we can't predict the risk of readmission well, and even if we don't have a great model to implement right now, it is an opportunity to start collecting better data during the hospitalization. These would be things like housing status, access to care, health literacy, substance abuse. Think about workflow and feasibility of data collection when adapting risk assessment tools. So again, I had made this point before, but avoid overly complicated models that impede workflow. They just won't they won't stand the test of time. And again, if you're going to use these for intervention purposes, the data must be available in real time. There is a single center study in Texas that actually created an overlay in their EMR that was able to pull out data that they were able to successfully use in a heart failure transitional program. And then other opportunities would just be simple surveys. They could be incorporated into nursing intake during hospitalizations, for instance. And then finally, we don't know how many readmissions are preventable. More than 0% of readmissions are preventable, but we don't know exactly how many. There was a recent review actually in CMAJ that looked at studies evaluating the potential preventability of readmissions, and they found a broad range. They said 5 to 79% of readmissions are preventable, and the median was 27%. And so I think it's an understudied and unclear area. But it is an opportunity for us to think about additional metrics to measure peri-discharge care. So simple things. We've all talked about simple clinical things that probably should be done. Timeliness of discharge summaries and their completion and communication. Patient satisfaction measures and other things are all possible. And that's it.